The next segment of our Sub-I Summit will be a four-part lecture series that will hone in on the basic skills and foundational knowledge you'll need to shine. We'll be kicking things off with the fundamentals of how to read an X-ray led by Dr. Moghtaderi. Dr. Moghtaderi is an orthopedic surgeon specializing in hand, wrist, and elbow surgery at George Washington University. He completed his residency training at Montefiore and fellowship at the University of Pittsburgh Medical Center. He serves as the program director of the GW Orthopedic Surgery Residency Program. And now we'll pass it off to Dr. Moghtaderi.
Thank you very much. Are we successfully seeing my screen?
Yes, looks great.
Great, thank you. So for this talk, we're going to go over the how of looking at X-ray, not the what, not what's in the X-ray. You'll have additional opportunity to talk about that, but the process of how you should go about interpreting it and then presenting that interpretation. So in orthopedics, we care very much about our X-rays. We obsess over them. They're the main tool that we use, and it's like the tool of our trade. It's kind of like how cardiologists look at EKGs. If you're being asked by a cardiologist to interpret an EKG and you just tell them that there's like a regular rate and the person's not having a heart attack, that's not going to be enough for them. They have their routine, they have the order that they look at things. And you gotta, when you're on the medicine service, you gotta learn that if you have a cardiology attending. So we're the same way in ortho. We have a particular way of doing things, and the sooner you learn our way of doing it, the sooner you're going to look good and you're going to be correct in interpreting X-rays for us. And as a sub-I, you definitely want to be both correct and look polished doing it. So both of those are your goals. You want to do it in a way that it fits in with how we do our work, but also separate from how you look as a sub-I. You want to be correct and accurate and complete. So what about the first part? Well, there are conventions that we have that you need to learn and to go with. And the first one is every time you're asked in front of the group to look at an image, you have to start with this introductory sentence. You have to say, what are we looking at? And that includes talking about what kind of image is it? It's an X-ray, which part of the body it is, and what kind of views you have. And this one specific fact, which you may not have thought to include, which is whether there's skeletal maturity or not. So basically, before you get to telling us about the findings, tell us what we're looking at. And these are some examples, right? So you might say we have 3 plane views of a skeletally immature right hand. You got to say this before you start talking about the hand itself. If you don't, the people listening to you are going to fidget in their seats because you're not doing it the way they were expecting to do it. And as a student, you don't want to make your audience fidget in their seats because you're not doing it the right way, right? Those are obstacles you don't want. If you know the name of the view, you can say it, like AP lateral and sunrise view. But it's okay at your level if you don't already know the name of the view. You can at least say there's 3 views, right? The simplest way is, there's a front view and a side view. Now you might use AP and lateral for those words, but the key is you want to say what it is you're looking at before you start digging into the contents. This is another tendency of how we tend to, especially as learners, you're not sure, you have doubt. So you say that out loud. You throw in a lot of qualifiers in what you're saying. Resist the urge to do that. Resist the tendency to do that. Recognize that we all have a tendency to do this and delete that from what you say, sort of with your outside voice. Now, it's okay to have uncertainty about the finding. And if you are trying to convey uncertainty about the finding, you should use these words, right? So let's say I want to say there may be a non-displaced fracture, or this may represent, a trabecular line. I'm going to say that. That's actual uncertainty in my assessment. But if I think I see a fracture, I don't have to say, I think I see a fracture. Everyone who you're listening to already knows that you're telling them what you think you see. So it's just more polished. Similar thing is we tend to throw in just a lot of filler words because that's how we process as we're looking at something and we're thinking about it. We throw a lot of ums and ahs and things like that. If you just recognize that you're going to do that, and again, silence that tendency, that moment of silence is going to sound more polished. It's okay to take a beat when they put up an X-ray. Take a beat to look at it and then tell them what you think, right? Recognize that that's how it's going to go, and it's going to sound more polished that way. So that's how you come across polished. That's how you fit into the convention. But now, how do we actually go through reading the X-ray? Again, we're not going to focus on actual X-rays here. We're going to focus on the process. We'll do the X-rays later. So we put this up. We asked you to look at it. There's a fracture. You start telling me about the fracture, but we already did something wrong, right? The first thing I should have said about this is that this is an AP view of a humerus in a skeletally mature individual. And then I start talking about the fracture, right? That was just a review to see if you were listening. But this is low-hanging fruit. It's very clear once I say the introductory sentence what I'm supposed to talk about here. But what if I put up this X-ray and ask you to talk about it? Now you stand up, yeah, 3 views, ankle, etc. You get that out of the way. But then it looks like a normal X-ray. So what are you supposed to do? You just say, it's a normal X-ray. As a sub-I, that doesn't look good. But also for yourself, you may miss something. You may be incomplete. It may come, there's nothing that you can see from across the room, but you want to have a process to go through and make sure you've looked at this completely. So you want to have an algorithm that you're going to apply to every film that you see. You guys got all taught in medical school how to look at chest x-rays, right? They tell you, don't just jump to the heart and lungs. Don't immediately look for CHF and pneumonia. Look at the mediastinum, look at the ribs, look at the diaphragm, all the things that wouldn't jump out at you, but you have to go through your list to make sure you're correct. So we're going to do the orthopedic version of that, and that's going to be the rest of the talk here. So my algorithm has 4 sections. You want to have these 4 sections, and then if someone puts up an X-ray in front of you, you just go through these. Okay? Now, when I put up this X-ray, okay, my first one was fractures. Then we'll come back to the list, don't worry. Do I see any fractures? I'm going to silently follow the edges of all the bones, see if there's any interruptions, look at all the joints, and then I'm going to say, I don't appreciate any fractures, right? But make sure you did look before you say that. That's another tip. It looks bad if there is a fracture and you say, I don't appreciate any fractures. Then there was malalignment, right? I don't see anything subluxed here. So I might say that out loud. I might say the ankle joint is congruent without any sign of subluxation. Degenerative disease, I'm going to think about that. Well, the joint surfaces, there's preserved joint space. There are no osteophytes. And I can say these things out loud, right? I'm showing my work. I'm showing that when I interpret this X-ray, I'm taking all of these things into consideration. And I sound better and I'm more complete because I'm going down my checklist. And then the last one was lesions or soft tissues. So I look around. Oh, I see actually over here, I see an osteophyte at the posterior calcaneus. Maybe I wouldn't have noticed that at the beginning, right? I see osteophytes at the posterior and plantar aspects of the calcaneus. Done. Now that sounds like an interpretation of someone who knew what they were looking at, even though we put up a film that's essentially a normal film. You know you're complete if you were doing it for yourself, and you showed that you're complete if you're doing it in front of others. So we had our 4 categories, right? And now we're going to go through each of these or through some of these. And what we're doing here is we're building a flow chart, and you're seeing a piece of the flow chart now, but at the end, you're going to see the whole thing come together. So follow along the best you can. The most obvious and the most complicated part of this flow chart are fractures. Not the only thing we look at on our X-rays, but it is the part with the most pieces. So if we go through that, now we're zooming into fractures. You want to describe every fracture the same way every time and not jump around. And you want to give enough information. The model you're thinking of is if someone's listening to you on the phone, describing this X-ray without looking at the X-ray in front of you, they should be able to figure out what you're what you're seeing. Like they should be able to draw a schematic picture of the fracture. So you want to give just enough information to convey that. You're going to have four things about the fracture that you're going to say every time. So we had four categories. Now here we're zooming in. This category has four things. You're going to do this in order and not jump around. It's confusing to your listener if you're jumping around between things. And remember, you never want to have your listener on edge. That's the whole point of this. So what bone? Sounds straightforward, right? Well, as a sub-I, you're learning this, right? So before you start your sub-I, we only have four limbs, right? There aren't actually that many bones that you have to know the names of in ortho. But you don't want to call a metacarpal a phalanx or vice versa. That's going to put your hand surgeon attending on edge a little bit about you. So simple. Where in the bone? So we're starting out big and we're going to zoom right down into our fracture. So what bone was it? And now where in this bone are we? How do you describe where in the bone? Well, you could use the names of the parts of the bone if you know them, right? It's okay to say shaft instead of diaphysis if the word didn't come to you. The diaphysis is the shaft of a long bone. The metaphysis is where it gets wide and transitions. And the epiphysis is the part past the physis. Now, you don't see the physis or the growth plate on an adult bone, but the epiphysis is the part between the physis and the joint surface. So you could use these as your terms. You could use geographic terms, right? Divide the long bone into thirds. It's a shaft, it's a fracture in the distal 1/3 of the bone, for example, right? Or the middle 1/3. Or you can use these to narrow down further. It's a fracture in the junction of the middle and distal thirds. Whatever vocabulary you want to use, the point is you're conveying to your listener who maybe isn't looking at the x-ray, before you start telling them the shape of the fracture, you're telling them where it is. We always care about what's happening at the joint. So if it involves the joint or it's near the joint or it goes into the joint, you want to say that. And then as you start learning the specific names of the different parts of specific bones, you can use those. For example, you might learn at some point that this is called the neck of the radius, the part right before the head of the radius at the proximal end. And so you could use that and say there's a transverse fracture at the radial neck. And then we get to the fracture pattern. So here's some common fracture patterns. The simplest one is a transverse fracture. We're not going to get too much into the mechanism of these, just about recognizing them and describing them for the purpose of this talk. But transverse fractures happen when you take a long bone and you get a bending force on it. This is a butterfly fragment, which is this triangular shape. A butterfly fragment is actually just a transverse fracture that split before it went all the way across. Generally speaking, the more pieces a fracture generates, the more energy there was in it. So a lower energy bending is going to give you a straight transverse, and a higher energy is going to break it up into more pieces, whether it's one butterfly or multiple. This one's an oblique fracture, which is just a crooked transverse, and then this one's a spiral. What's the difference between spiral and oblique? I'm going to leave that as extra credit for you to figure out and ask me about it later if you don't. And then you can also have combinations. You can have a transverse fracture with intra-articular extension. So just put the parts together from the vocabulary that you learned. Relevant features, as I said, intra-articular involvement, you always want to describe. Comminution, you always want to describe. And then we get to displacement. So we had four categories. We're zoomed into one of our categories, fractures. And now of the four aspects of that, we're going to zoom into this one, which is displacement. Displacement has four components: angulation, translation, length changes, and rotation. This is like a vector. So in high school, you learned about vectors. A vector has a direction and a magnitude, but a vector can also be broken down into components. So you can break it down into the x-axis and the y-axis to get the total vector. The same way for displacement. The displacement is how much the bone piece moved from where it's supposed to be, but it can move in these four different ways, and they can go in a direction and an amount for each of these. This is what gets confusing for students, but learning that you can break this down lets you work through it. We have a convention, just like we have a convention about that introductory sentence. We have a convention that we always describe displacement in the direction that the distal fragment went. This might sound confusing, or it may sound totally intuitive, but it's not always intuitive. So you have to recognize that this is a convention and always describe it in this fashion. So we said there's four types. There's angulation, if the bone is bent. There's translation, if the bone moves over. There's length, if it's shortened or distracted. Here, it's shortened by overlap, which we call bayoneting. You can also shorten by impaction and crushing into each other. And then there's rotation. Now, notice this doesn't really look that wrong because you can't tell rotation often on a two-dimensional image. But you can also have components of these, right? So think of the vector analogy. You can have the real, true total displacement be angulation and moving over and shortening a little bit, and you want to break that down and describe each component. For every component, you're going to say what kind it is. It's going to be angulation. What direction is it? And these are the words we're going to use to describe direction. And how far you want to quantify it, right? So there's 30 degrees of dorsal angulation, for example. And that includes all the parts of that. I want to talk about angulation for a moment because this is sort of the least intuitive of all the displacements, and students often confuse this. This is not a separate category. This is just one of the axes of our displacement category. You describe the angulation the same way that you describe the translation or the length or something like that. It's just you don't promote it to a higher bullet point level. It's tucked in under displacement. Just like any other displacement, we always talk about which way the distal part has tilted. It's a little counterintuitive because there's a pointy end whenever you have an angulation, and sometimes you think the intuitive thing is to describe the direction of the pointy end, but that is not the way we do it. We describe the direction of the distal part. Now, to make it more confusing, you can describe the direction of the pointy end. That is a way we do it. It's just not our default way. And if you want to do it that way, you have to use this buzzword apex. So you have to say apex lateral angulation, which is actually synonymous to medial angulation, and vice versa if it was the other way around. So I'll show you a couple of examples of that in a second. The other two angulation-related words that you have to know are varus and valgus. These are shortcuts. You don't have to ever use the word varus or valgus, but you do need to know what it means because other people may use it in front of you. These are shortcuts that describe angulation in the coronal plane, and varus is a shortcut for saying apex lateral, and valgus is apex medial. So here are some knees, right? Our normal knees have some degree of valgus angulation. So that if you look at the line that the femur makes and the tibia, the knees are pointing a little bit inward. That's not a straight line. It's exaggerated on the picture on the right, which is labeled valgus, but that's really more valgus than the natural valgus. Pointy end towards the midline is valgus. Pointy end pointing outward is varus, and that's like the knock-knee appearance you see in the middle picture. And this can apply to describing a knee, an elbow, a toe, an ankle. It doesn't matter. As long as you're in the coronal plane, whether you're describing the body part or the X-ray, these are words that we use. The mnemonics or the memory aid I use is varus. Sounds like a harsher word than valgus because R is this sharp sound, and the sharp part is pointing out on varus. I don't know if that makes sense to you, but somehow when I was a student, it made sense to me. Varus sounds like a pirate would say, you know, it's sharp and dangerous. Angle is pointing out towards you. So here's a test example for you. These are ankles with angulation in this plane. Which one of these is showing medial angulation and which one is showing lateral angulation? You can see the angle is opposite for each of these photos, right? So The one on the left is lateral angulation, if you're going to describe it using those words, because the heel, the more distal part, is lateral, the opposite on the right. You could alternatively use the word apex to reverse the convention and say, I'm now going to describe which way the pointy end of the angle is. So I'm going to describe the one on the left as apex medial. Or you can use varus or valgus, right? So which one's valgus, which one's varus? The pointy ends are pointing outwards on the one on the right. So that one is varus. Okay. So we had our four categories. We did fractures. Misalignment is really straightforward because we're going to use all the same words and conventions that we just learned about for describing the displacement of a fracture, but you're going to use all the same words and conventions and orders to describe any displacement, even if it's not a fracture. If a bone is dislocated, you're going to use the same axes of displacement to talk about it. Sorry, I didn't realize these were animating themselves. But then DJD, or degenerative changes or arthritis, um, that further breaks down into the four signs of arthritis on X-ray. You should know these. We're not going to really get into them, but these are the radiographic signs of arthritis. We actually like to ask this. Somebody will, at some point on one of your sub-Is, ask you to tell them the four radiographic signs of arthritis. Here's a quick example. AP and lateral views of the knee. I see osteophytes at the dorsal femur, at the proximal and distal patella, at the medial tibia, right? So those are examples. Here's a really bad example. There's no joint space left, right? This is a really bad example of arthritic knees, and you can get into finding all four of those components here. What else do you see in this X-ray? Alignment, right? These are varus knees, and so you want to say that. You want to recognize that. So let's wrap up and put it all together. You're always going to start with your intro sentence, always, regardless of what kind of imaging there is. Then you're going to get into the algorithm, which is going to have four parts. You're going to remember this checklist of four parts in your mind. You're going to go through all four of them for every X-ray. For fractures, there's four subcategories. Which bone, where in the bone, what's the fracture pattern, what's the displacement. For every fracture, you're going to go through all of these in a consistent order. You're not going to jump around. And then for displacement, we had four ways in which it's going to get displaced. And for every displacement, you're going to go through and comment on any of these. And for each of these, you're going to say the type, the amount, and the direction. You want to have order and structure to how you're going through all this. Talked about the different aspects of alignment and DJD, and then our catch-all for describing any soft tissue lesions or other bone lesions. And then the last tip is when you think you're all done, say one more thing. Find one more thing to say about the X-ray. And if you force yourself to do this, that will force your eyes to take one more lap around the X-ray. And this is how you're going to catch yourself from missing things, because you may have been describing that obvious fracture in the humerus that I showed you and not realize that the elbow is actually dislocated as well, right? So whenever you think you're done, take a moment, run your eyes one more time around the image and find one more thing to say, just as long as it's true. Say, there's no arthritis or something like that. I was going to go through this as an example, but for the sake of time, we'll keep going. So I had put together a written guide that basically summarizes the rubric and the tips that I said. This has been floating around on the internet for a few years. You might have already come across it or used it before, but now it has a home. So now you can go to this website, readingorthoxrays.org, and download this guide, which is basically the talk that I've been giving you today. Okay, that's it.
Awesome. Thank you, Dr. Moghtaderi. So that wraps up our intro lecture. Thank you so much for a wonderful lesson on X-rays that I know we'll all be putting to use throughout all of our sub-Is.